Good evening, colleagues. In 1945, Terence Millin published a landmark paper in The Lancet on his retropubic prostatectomy. A new technique would reduce the mortality for open prostatectomy from perhaps 15% to 3%. He became world famous overnight for his contribution to male health and was recognized in 1955 with the prestigious Francis Armory Prize from the American Academy of Arts and Science, among many other awards. Terence Millin was elected President of the Royal College of Surgeons in Ireland for 2 terms in 1963. And he was instrumental in rejuvenating the undergraduate part of this college, which is now a University of Medicine and Health Sciences. This evening, I have a great honour of introducing Professor Shirley Potter, who will present the 45th Millin Lecture. Shirley graduated from NUI Galway with both a medical degree and an intercalated BSc in anatomy. Following basic surgical training, she completed a PhD in tumour biology at NUI Galway and was awarded the HRB Clinical Scientist Fellowship. She subsequently completed her specialist surgical training in plastic and reconstructive surgery in Ireland and moved to Australia to do a few fellowships. Her fellowships were in microvascular cancer reconstruction at the Peter MacCallum Centre, Melbourne, and reconstructive microsurgery and brachial plexus at St Vincent's Hospital and the Alfred Hospital, Melbourne. She further developed her interest in reconstructive microsurgery at Changgung Memorial Hospital, Taiwan. She's been working as a consultant at the Mater Misericordiae University Hospital, Dublin since 2018, where her subspecialty interests are melanoma and advanced skin cancer, as well as head and neck microvascular reconstruction. I'm delighted to invite Shirley to give her lecture, Malignant Melanoma, an Unlikely Poster Child for Personalised Cancer Treatment. You're most welcome, Shirley.
Good evening, President, Vice President, members of Council, colleagues, trainees, students, friends and family. It's my greatest honour to deliver this, the 45th Millin Lecture, entitled Malignant Melanoma, an Unlikely Poster Child for Personalised Cancer Care. I joined 6 very esteemed female surgeons to become the 7th female to deliver this lecture in its 45-year history. However, what makes me most proud is that I'm here today representing a relatively small yet expanding specialty as the first plastic and reconstructive surgeon to have this honour. As it was said of Millin, I stand on the shoulders of the giants of Irish plastic surgery, many of whom I'm delighted to see here in the audience today. I consider myself very lucky to call the Mater Hospital my place of work, and am honoured to represent this fantastic institution. This lecture honours Terence Millin, who created his own path and left his trail on surgical history, with his descriptions of retropubic prostatectomy. He's remembered for his work ethic as a surgeon, as well as his role as a surgical innovator, trainer, researcher, and sportsman, all attributes that underpin my daily life as a surgeon. Millin was born in County Down and spent most of his working life in the UK. He returned to Ireland in 1950 and lived in Byblock's house just outside Doneraile in County Cork. This house has since been demolished, and all that remains are the gates, seen here in the central photo. This photo was taken last week by David O'Flynn, father to my friend Sharon, who's here in the audience, whilst he was out on his daily walk. Over the course of this lecture, I'll discuss the history of melanoma as a disease, the evolution of the contemporary management of melanoma, and the Irish melanoma picture. And then I'll talk about my personal research and clinical journey with melanoma. Melanoma comes from the Greek word meaning dark tumour, and its history is well described in this article by Vernon Sondak, who's a superstar in the world of melanoma surgical oncology, and we were delighted to welcome as plenary speaker to our national meeting last year. The first recorded descriptions of melanoma appear in the writings of Hippocrates in the 5th century BC, and melanotic metastases were found in the Peruvian mummies in the 4th century BC. Scottish surgeon John Hunter is credited with the first removal of a melanoma, while Laennec, who's better known for inventing the stethoscope, was the first to realise melanoma as a distinct disease entity. Other notable contributions were Wallace Clark, who described levels of invasion in the skin, and more importantly, Alexander Breslow observed that prognosis was a function of tumour thickness, and the Breslow thickness remains our main prognostic indicator in melanoma today. Notable surgical contributions were from William Handley, advocating margins as wide as 5 centimetres for the primary removal of the lesion, and Herbert Snow, who advocated prophylactic resection of all draining lymph nodes at the same time. Thankfully refined further by Donald Morton with the pioneering technique of sentinel node biopsy in the early 1990s. 2 quotes are worth highlighting, and the first being from Thomas Fodington, who said, "As we have no positive indications to guide us towards the cure of melanosis, the treatment directed is of course purely palliative," which unfortunately held true until recent times. And that of Samuel Cooper, who recognised that the only chance for benefit depends on early removal of the disease, a statement that still largely holds true today and is borne out in our key performance indicators. So personalised medicine has long been the mainstay in the treatment of melanoma, involving surgical decisions that are individualised on the basis of measured differences as small as 0.01 of a millimetre. However, it's in the field of immunotherapy and targeted therapy that melanoma has become the poster child for modern oncology drug development. Prior to 10 years ago, treatment options for melanoma were limited to toxic chemotherapy regimens that had partial treatment responses at best and made little differences to overall survival. Over the past decade, great strides have been made in unravelling the unique biology of melanoma, revealing it as one of the most immunogenic human tumours. And many of the contemporary immunotherapy regimens used across oncology today were first discovered in melanoma. Immunotherapy stimulates the body's immune system to destroy cancers, allowing the body to recognise and target the antigens on the surface of tumour cells. Immune checkpoint inhibitors, or immune checkpoints, dampen down the immune system, and some cancers, such as melanoma, use these to their advantage, essentially hiding from the immune system. To put this in surgical language, you can consider the immune system as a fast car, the T cells as the accelerator driving it forward, the antigens as the steering wheel directing it where to go, and the immune checkpoints as the brakes. Checkpoint inhibitors, such as anti-CTLA-4 antibodies and anti-PD-1, PD-L1 antibodies, remove the brakes and drive the immune system in the direction of the tumour antigens. In the melanoma space, several practice-changing publications started to emerge around 2010, with immunotherapies showing survival curves never seen before in melanoma. The discovery in 2002 that approximately 50% of human melanomas harbour an activating V600E mutation in BRAF first raised the possibility that melanoma may be amenable to targeted therapy. BRAF is an upstream component of the growth-promoting MAP kinase pathway, which melanoma cells are dependent on, and a remarkable 81% of BRAF mutant melanoma patients had a response to treatment. Although many more immunotherapies and targeted therapies have come on stream since, management of drug resistance, immune-related side effects, and the timing and combinations of treatment options remain the focus of current work. So given our Celtic fair skin and the fact that most Irish people wear a suntan as a badge of honour, skin cancer is a major public health problem in this country. Skin cancer by far outweighs most of the common human cancers and is reflected here in our national statistics. And although this puts significant pressure on our health resources, thankfully, if caught early, most cases cause low morbidity. Melanoma is one of the most aggressive human tumours, and its incidence and mortality in Ireland are amongst the highest in Europe. Unlike most other cancers, its incidence continues to increase year on year, with about 1,300 cases expected here in Ireland this year. It's currently the 4th most common cancer in men and women, and we're currently facing what's called a melanoma epidemic, as it's expected to become the 2nd most common human tumour by 2040. Melanomas generally present as a changing mole, the majority occurring as a new mole or de novo, and 25% occurring in a pre-existing lesion that changes. There's generally an equal male to female incidence, males tending to get them more in the trunk and females on the limbs. 10% of melanomas have a genetic link, while most of them are caused by UV light exposure. And in terms of sun damage, we see 2 broad categories. Melanoma is caused by the chronic lifelong sun exposure that often presents later in years, often on the head and neck area, and generally are BRAF non-mutant. versus melanomas that present in earlier years due to short, sharp bursts of blistering sunburn and sunbeds that tend to occur on the limbs and trunk and are often BRAF mutant. So with that as background, for the rest of this talk, I'll try to weave my personal journey, starting off learning about basic disease biology, through to surgical training and practice, with the journey of a patient from disease initiation, diagnosis, surgery, and further treatment. These are screenshots of some medical notes I found from my earlier years in training. And as I alluded to earlier, they paint a dismal picture for the melanoma patient at that time, with poor survival rates, toxic treatment regimens that had poor response rates and little or no effect on overall survival. To me, it was obvious that much needed to be learned about the biology of these aggressive tumours. At that time, I decided to do a PhD to learn more about tumour biology in general, and I joined Professor Michael Kern's lab in Galway under the direct supervision of a very diligent scientist called Roisin Dwyer, and this was part of a HRB-funded clinician scientist programme. I spent 3 years studying the tumour microenvironment using breast cancer as a model, gaining key insights into how tumour cells interact with their surrounding stromal cells, using chemokines as paracrine signalling molecules, and how tumour stromal cells are essential drivers of tumorigenesis. Using techniques such as chemiarray, ELISA, and PCR, I characterized the secretion and expression profiles of a range of chemokines in the cells in the breast tumour microenvironment. I showed that tumour stromal cells induce significant chemotaxis of breast cancer epithelial cells using transwell migration assays, and found a dose-dependent increase in migration in response to certain chemokines, an effect blocked by antibody studies. When breast cancer epithelial cells were cultured with tumour stromal cells, they showed distinct changes in cytoskeletal architecture and cell polarity. And when breast cancer epithelial cells were co-cultured with tumour stromal cells and then separated with epibeads, epithelial cells showed changes in chemokine and cognate receptor gene expression, as well as expression of a range of other tumour-associated genes, and also genes involved in epithelial to mesenchymal transition. So taken together, these findings suggest that direct contact with tumour stromal cells induces increased invasive capacity on breast cancer epithelial cells. In vivo co-implantation models, I found that mixed stromal xenografts had significantly higher rates of tumour formation and tumour volume compared to tumours formed from epithelial cells alone, and again showed increased expression of tumour-associated genes. Plasma levels of the chemokines were significantly higher in breast cancer patients versus controls and correlated with clinical prognostic indicators such as tumour grade and subtype. So in summary, breast cancer stromal cells possess striking tumour-promoting properties with the ability to modify the phenotype and genotype of breast cancer epithelial cells indirectly through paracrine mediators and also directly through cell-to-cell contact. This detailed characterization of the crosstalk between these two cell populations highlighted stromal epithelial interactions, or stromal cells themselves, as possible targets for novel breast cancer therapies, examples of which are in clinical trials today. At my PhD viva, after discussing the resultant publications that I was involved in, I was asked by Professor Kern how was I going to use what I had just learned in my future career as a plastic surgeon. And my response was that I was going to do a similar body of work in melanoma. It became obvious in my clinical years that followed that melanoma biology didn't really follow the normal patterns of malignant behavior. And although a percentage of melanomas spread first to the regional lymph nodes, circulating tumour cells appear to travel in parallel to distant sites, and it's likely that there's continuous seeding of all sites. For this reason, it's unlikely that surgery alone was ever going to be a cure for melanoma. So as mentioned, melanoma is one of the most aggressive human malignancies, and it's largely due to unique properties of melanoma cells. Many of the clinical challenges we face today are attributable to these aggressive properties. Melanoma cells have the highest mutational load of any human tumour, with 80% showing UV signatures. They show pathway plasticity, diverting activity from one pathway to another to avoid cell death. They can de-differentiate into a variety of stem-like states and survive in hostile environments such as the systemic circulation. And they have an intrinsic ability of self-renewal, with just one cell capable of reconstituting a whole tumour in mice, a property that's unique among human tumours. And then something that particularly resonated with my PhD work was that they can reprogram adjacent stromal cells to secrete growth factors and chemokines to promote aggressiveness by paracrine and autocrine mechanisms. This led me to set up the PREDICT-MM trial in the matter to investigate the role of extracellular-derived vesicles or chemokines in the melanoma tumour microenvironment. This work was done over the last 2 years as part of the Irish Clinical and Academic Training Programme funded by the HRB and the Wellcome Trust. For those of you that are unaware, the ICAT programme is an integrated clinical and PhD programme allowing specialist trainees from all disciplines around the country to integrate a PhD into their specialist training with the aim of creating a recognised path for clinician scientists of the future. I was lucky enough to recruit Dr. Stephanie Bollard, one of our plastic surgery SPRs, who's currently the first and only surgical trainee on the ICAT programme. And the work that follows has formed the first 2 years of her PhD, and she's already had the opportunity to present it to many important audiences. So to introduce this work, extracellular vesicles, or EVs, are a relatively recent discovery. They're tiny lipid-bound nanoparticles released from all living cells and are laden with proteins, DNA, and RNA. They're detectable in most body fluids and are key mediators in cell-to-cell communication. When dealing with extracellular vesicles, the majority of the work goes into isolation and characterization to ensure you have a pure population that is representative of the cell of origin. EVs are known to have key roles in cancer progression, in particular signaling within the tumour microenvironment and between tumour and metastatic sites. There's a growing body of evidence that shows that EVs may have roles in melanoma, driving tumour growth, progression, and metastatic spread. Given that, when isolated properly, they have a signature reflected of their cell of origin, they show promising clinical potential as diagnostic or prognostic biomarkers, markers of treatment response, or even agents for targeted drug delivery into the tumour microenvironment. To investigate their role in melanoma, we recruited newly diagnosed and metastatic melanoma patients at the Mater Hospital. EVs were isolated from plasma samples as well as from resected melanoma specimens and melanoma cell lines. Their chemokine content was analysed, as well as proteomic and metabolomic signatures. Matched formalin-fixed paraffin-embedded specimens underwent laser capture microdissection to separate tumour and stroma with subsequent immunohistochemistry and PCR analysis for targets of interest. This is the patient population we've recruited so far, representing a typical melanoma patient population that presents to our clinic. Using nanoparticle tracking analysis and size exclusion chromatography, we've successfully isolated and characterized pure populations of EVs from our patient cohort, in accordance with the various criteria set out by the MISEV guidelines. Using Western blot, published EV datasets, and transmission electron microscopy, we've confirmed the presence of expected EV markers and typical cup-shaped morphology of our EV particles, again proving we have a pure population of melanoma-derived EVs. Using the same techniques, we've isolated pure populations of EVs from melanoma cells in culture, both primary tumour melanoma cells and cell lines. We've shown that EVs derived from whole tumour samples, as well as the individual cell populations that constitute the tumour microenvironment, contain a range of chemokines. And interestingly, similar patterns of chemokine content are seen in the EVs of melanoma patient plasma, suggesting that circulating EVs are reflective of the tumour microenvironment. Certain chemokines, such as CXCL8 and CCL5, have caught our interest and will form the focus of future work. When we co-cultured melanoma-derived EVs with dermal fibroblasts, using chemi-arrays, we found that chemokine secretion profiles of the fibroblast changes. And we quantified these changes using ELISA, and you can see here in red the increased secretion of chemokines by dermal fibroblasts when they've been exposed to melanoma-derived EVs, with CXCL8 and CCL5 again emerging as chemokines of interest. This suggests that melanoma cells use EVs to reprogram the surrounding stromal cells within the tumour microenvironment. Currently, we're working on staining for CXCL8 and its cognate receptor on our matched tumour specimens, and these will then undergo laser capture microdissection to separate tumour and stroma with final PCR analysis for protein expression. A comprehensive metabolomic analysis of our melanoma EVs has revealed that they carry a vast array of metabolites, depicted here in this heat map, with each row representing a different metabolite. we're currently using various imputation methods to detect any clinical relevant signatures that are emerging from this vast amount of data when we compare disease state to controls. Using mass spectrometry, we've carried out a large-scale study of the protein content of our EVs, or proteomic analysis. And the heat map on the left shows unsupervised hierarchical clustering, red representing increased protein content. We've revealed a proteomic signature associated with metastatic melanoma, which is not evident in healthy controls. And using post-hoc string analysis to identify protein-to-protein interactions, we've identified a key protein linking our two chemokines of interest, CXCL8 and CCL5, called PF4. Platelet factor 4 is already known to have as an inhibitor of these chemokines in other diseases and has a role in reducing chemosensitivity in cytotoxic agents. Furthermore, the volcano plot on the left and the principal component analysis on the right show differentially expressed proteins between metastatic melanoma patients and controls. Those in the red are higher in patients with metastatic disease compared to those in the blue that are higher in controls. This shows that we can detect a unique signature of proteins in the extracellular vesicles of melanoma patients, and PF4 is again highlighted in the metastatic group and will form the focus of future work. A final aspect of this work that's worth mentioning is the comparative oncology, which involves studying the same disease in humans and animals with the aim of benefiting both species. Each year in Ireland, several dogs are diagnosed with canine melanoma, and it's a naturally occurring form of melanoma, accounting for 7% of all canine tumours. Not much is known about it, except that it occurs in low or high-grade forms, with the high-grade progressing very quickly with a disease course of about 6 to 12 months, and with very few treatment options. We know that EVs have similar characteristics in dogs and humans, and that CXCL8 has associations with canine melanoma. So we've recruited 10 dogs of various breeds who have been treated for melanoma at the UCD Veterinary School. We've successfully isolated and characterised pure populations of EVs from these canine plasma samples. And using similar methods to the human study arm, we will analyse their protein content and immuno-oncology-related gene expression profiles with the aim of identifying similarities or key differences with human melanoma, and in the hope of identifying ways to benefit diagnosis and treatment of canine melanoma. So in summary, we've successfully isolated a pure population of EVs from melanoma patient plasma, as well as from the cells in the melanoma tumour microenvironment. We've profiled the chemokine content of melanoma-derived EVs and identified key targets of interest. We've shown that melanoma cells use EVs to communicate with and potentially reprogram nearby stromal cells in the tumour microenvironment. And we've profiled the metabolomic and proteomic content of these EVs in melanoma patients, and have identified a unique protein signature that differentiates metastatic melanoma from healthy controls. Extracellular vesicles and their chemokine content play key roles in cell-to-cell communication in the melanoma tumour microenvironment, with potential therapeutic targets emerging. And proteomic signatures of circulating extracellular vesicles can identify metastatic melanoma from controls, pointing to their role as potential biomarkers to monitor disease, relapse, or response to treatment. So at this point, I'd like to segue back into my clinical practice to show how I've tried to address some of the key challenges encountered along the melanoma patient journey. I was fortunate to learn best-in-class melanoma care at Peter MacCallum Cancer Centre in Melbourne, where, while on fellowship, I saw the landscape of melanoma management move towards personalisation. And in the last section of my talk, I'll briefly discuss some of these areas. It's become obvious that melanoma is a heterogeneous disease, and current prognostic indicators only crudely stratify our patients. Given that a significant amount of melanoma patients are young and well-informed, and they understandably demand and deserve more information. On the left is a set of risk prediction tools developed by the Melanoma Institute of Australia and freely available online. I now use these in my clinic, in particular to explain the chances of a sentinel node being positive, and we're currently validating these in an Irish cohort. The tool on the right is an example of one of the gene expression profile tests that are used in clinical practice around Europe to identify patients that can safely forego sentinel node biopsy. And this is the direction that clinical management of melanoma is taking. Early removal of the primary tumour is critically important to disease control, and this is highlighted by our KPIs issued by the NCCP, stating that melanomas should be seen within 6 weeks. To address this, we've set up a See and Treat skin cancer service at the Mater Hospital and have shown a 50% reduction in waiting times for surgery with no compromise in their clinical outcomes. Significant cost savings were noted, and most importantly, excellent levels of patient satisfaction. We've recently been awarded funding as part of the Hospital Innovations Funds from the NDTP to develop this service further with assistance from our Mater Transformation Office and the National College of Art and Design. Surgical margins for melanoma are currently determined by the Breslow thickness of the tumour, excising down to but not including the fascia. These are the current guidelines that we tend to adhere to, with no evidence for anything more than a 2 centimetre margin. There has always been significant debate around margins for melanoma, and 6 large randomised controlled trials have been conducted involving over 4,500 patients, failing to show any difference in overall survival for narrow versus wide margins. However, these trials fail to reflect the contemporary management of melanoma, as they were largely done when sentinel node biopsy wasn't routinely offered and when adjuvant treatments were unavailable. The currently recruiting international multi-centre MELMAR trial is trying to address this. Having been involved in the early stages with Michael Henderson and David Gyorky and Peter Mack, I've since secured national funding to recruit Irish patients to this trial from several units around the country. After an year-long battle of red tape and ethics committees around the country, we finally got the green light from Cancer Trials Ireland last week and hope to start site initiation visits in the coming months. This will ensure that the results of this trial are relevant to our Irish melanoma patients. Since first described by Donald Morton in the early 1990s, sentinel node biopsy is critical to the current staging criteria for melanoma. It offers information on prognosis, as well as guiding decisions around adjuvant treatment, with all sentinel node biopsy patients being offered adjuvant treatments if suitable. We currently offer sentinel node biopsy to those patients that are PT1B and above, according to the recent AJCC classification, and previously melanomas over 4 millimetres would have tended to be excluded, but however, the majority of these are older patients. But 30% of these patients tend to have a positive sentinel node, and by upstaging them, by giving them the sentinel node procedure, you're qualifying them for further adjuvant treatments. So surgical management of melanoma has undergone significant changes in the last 5 to 7 years due to 2 practice-changing developments in the adoption of the MSLT2 and DCOC trials and the survival benefit of adjuvant treatments. Up to 5 years ago, completion lymph node dissection would have been the standard practice after a positive sentinel node. In the MSLT2 trial, sentinel node biopsies were randomised to completion lymph node dissection or active surveillance of the nodal basin with ultrasound. Both the MSLT2 and the German DCOC trial showed the same results, with a 26% in the active surveillance group developing nodal disease, and this likely reflected non-sentinel node disease in the lymph node basin. There were no difference in melanoma-specific or overall survival in either group. However, there was improved relapse-free survival in the completion lymph node arm, indicating slightly better local control. And most importantly, there was a 30% morbidity rate in the completion lymph node dissection arm, mostly in the form of lymphedema. And recently, 72-month follow-up was published in the JCO, confirming no difference in survival with completion lymph node dissection versus nodal observation, and in a further propensity-matched analysis for high-risk groups, again showing no difference. So currently there's no longer really a role for routine completion lymph node dissection after a positive sentinel node. So I'll briefly run through some of the stages of melanoma in terms of adjuvant treatment in the various stages. And the goalposts are constantly changing, moving more and more towards earlier disease, with recent evidence suggesting a role for treatment on high-risk stage 2 disease, so these are thick primary melanomas with a negative sentinel node biopsy. However, the side effect profile of these drugs for only a modest improvement needs to be considered. Adjuvant therapy for resected stage 3 melanoma is now standard of care. These are the sentinel node biopsy positive group. 9 randomised controlled trials have been completed with dramatic improvements in relapse-free and distal metastasis-free survival and data on overall survival awaited. However, again, there's a balance between treatment-related adverse effects and response, and decisions around whether to treat early or to treat on recurrence are still being discussed. In clinical stage 3, i.e. those presenting with palpable nodal disease, neoadjuvant therapies before surgery is showing very promising results, with 40% showing pathological complete response, and more importantly, the degree of pathological complete response correlating with relapse-free and overall survival, so acting as a prognostic indicator. Contemporary treatment options for patients with asymptomatic solitary or oligometastasis include upfront surgery followed by adjuvant immunotherapy, or upfront immunotherapy with salvage surgery as required. These decisions are complex, multidisciplinary, and individualised to patient and tumour factors, and trials in this area are needed. And just to give you an idea of the response rates seen in the metastatic setting, just over 10 years ago, 5-year survival rates of less than 5% were noted, whereas now 5-year survival rates over 50% are being achieved with various combinations of immune and targeted therapy. So surgery is still the mainstay for treatment of loco-regional disease in melanoma. Its role in the modern era is currently being redefined. Long-term follow-up data is needed, as well as predictors of tumour biology and response to treatment. Melanoma management is a complex and multidisciplinary field, requiring active participation of the surgeon, the medical oncologist, and the patient to guide treatment decisions in this rapidly evolving field of effective systemic therapy. So given that more and more melanoma patients are surviving, their quality of life after treatment is becoming more important. This is Melanoma Support Ireland patient advocacy group run by Kay and Miriam, 2 melanoma patients, and set up to address survivorship issues of this group. Patients have a lived experience of their disease, and we've tried to actively involve them in our research to make the findings relevant to both them and their families. We've had them involved in abstract writing, as authors on papers, and in virtual patient-focused research groups as seen here, breaking down some of the current evidence so that they can better understand about treatment decisions. And taking things one step further, along with active involvement of our patient group and recent generous funding resources, we're currently working on This is Skin Oncology, or This Is So, a personalised patient information platform that will roll out nationally later this year. And by being designed by patients, for patients, it will aim to address the unmet needs of this important group and their families. So over the past decade, great strides have been made in unravelling the unique biology of melanoma. And thankfully for patients, this research investment has paid off. Over the course of this talk, I've described my personal research and clinical journey with melanoma, and in that time, melanoma as a disease has transformed. From a time when little was known about its biology, outcomes were poor overall, surgery was drastic, treatments were generally toxic and made little difference to survival rates, to now, when bona fide therapeutic targets have been identified by unravelling the biology of this disease, surgery is becoming more refined, impressive survival curves are emerging, and the quality of life of those survivors has much improved. I hope I've convinced you that melanoma really is a poster child for personalised cancer treatment, but maybe also that even a plastic surgeon could be an unlikely poster child for academic surgery. This work has very much been a team effort, and I'd like to sincerely thank everyone involved, in particular my co-investigators Amanda McCann and Pamela Kelly in UCD, to Jane Howard and particularly Stephanie Bollard for their tireless work in the lab, my pathology colleagues in the matter, our clinical nurse specialists and interns all involved in sample collection, and to my plastic surgery colleagues in the matter for their continued encouragement and support. Also to the many collaborators in UCD, whose expertise has been invaluable, and most importantly to the patients who've donated their valuable samples to our research. The journey has been made very enjoyable by the many mentors and friends I've met along the way, as well as those interdisciplinary colleagues and friends who share my passion for melanoma and head and neck oncology in the matter. And I reserve my last slide for the most important people in my life. Thank you to my parents, my partner Cian, and my son Daniel for their unending support. And thank you for your attention.
Professor Potter, congratulations. You've just joined a long line of Millin surgeons who've made a huge contribution to Irish surgery, and I've no doubt you will be doing exactly that. So I will now present Shirley with the medal. And we'll have a few photographs.